Next problem in children is abdominal pain and jaundice and abnormal liver function test. You see here the scenario. You have an 8-year-old child or girl present with a 3-day history of abdominal pain lasting more than 20 minutes. It occurs before breakfast, sometime at school, where it will generally pass when she busies herself with activities. She has a tendency to constipation. Her pain worsens when faced with tests at the school or other stressors. Examination is normal. So when you face a child with such a problem and the clinical examination is normal, I mean no abnormality detected, there is no pallor, no tenderness, no mass felt, no pallor, the body weight is normal, she's thriving well, and this problem is linked to some stressful situation in her life. So you have to think of what? Yes, you have to think of functional abdominal pain. Functional abdominal pain. So this should be kept in mind. The other point, you should look for the hidden cause of abdominal pain, especially in girls, is the urinary tract problem. So you should ask about any sign and symptom of urinary abnormality. So you have to check for UTI. So here you see a graph or diagram about the cause of acute abdominal pain. Important thing to exclude is any surgical emergencies in this pain. Surgical emergency because it may be fatal. So you have to exclude acute appendicitis, intestinal obstruction, like intussusception, obstructed inguinal hernia, peritonitis, inflamed Mickels, and so on, trauma or pancreatitis. This is an intra-abdominal problem. Medical problem may be most important than specific abdominal pain, functional, gastroenteritis, UTI, inocular purpura, diabetic ketoacidosis. You should check for glucose in the blood and urine. Sickle cell crisis may cause pain. Hepatitis, inflammatory bowel disease like Crohn's disease, ulcerative colitis, and so on. Or it may be unknown cause. Extra-abdominal abdominal pain like UTI, urinary tract infection, and respiratory. So respiratory tract infection, pneumonia, or tonsillitis, upper respiratory, lower lobe pneumonia, torsion of the testes, you should look for genitalia, hip and the spine. These may lead to referred abdominal pain. So abdominal pain here, you see the scheme, whether focal or generalized. Generalized abdominal pain, you should look for any intussusception, surgical problem, gastroenteritis, constipation, diabetic ketoacidosis, intestinal obstruction, inocular purpura. Cases of focal depend on the anatomy or organ affected. So epigastric, gastritis, peptic ulcer, pancreatitis, so on, gastroesophageal reflux. Right upper quadrant pain, cholecystitis, liver problem, or right lower lobe pneumonia. Right lower quadrant, appendicitis, ovarian cysts, and so on. Upper left quadrant, splenic injury, especially in cases of trauma or abscess, or lower lobe pneumonia and pyelonephritis. Left lower quadrant, constipation, inflammatory bowel disease, gastroenteritis, and so on. Suprapubic bladder infection and pelvic inflammatory disease. So all these depend on the anatomy of the anatomical site of pain, and you should put a differential diagnosis. What are the signs and symptoms of organic abdominal pain? So you should mention the persistent right upper quadrant, lower quadrant pain, pain causing nocturnal waking, dysphagia, persistent vomiting, nocturnal diarrhea, GIT blood loss, familial inflammatory bowel disease, Crohn's disease, or persistent upper quadrant pain, or peptic ulcer disease. Peptic ulcer disease. Signs: unexplained fever, weight loss, or delayed puberty, arthritis, and perennial disease. These all indicate organic cause. So when you take history, physical examination, you check for red flag signs and symptoms of abdominal pain associated with these, so to exclude any organic cause. This is a case of appendicitis and appendectomy, an inflamed appendix, cause of right lower quadrant abdominal pain, tenderness, rebound positive. The child presented with fever and vomiting, and there is rebound tenderness, as I told you. Ultrasound shows an inflamed appendix, and the operation was done. So in the approach, you should take full history, physical examination, laboratory investigation. You should check for ESR, CRB, acute inflammatory, acute phase reactant, CBC, evidence of infection, liver enzymes, bilirubin and biliary or liver disease, amylase, lipase in case of pancreatic affection, urinary tract infection, general urine, bleeding due to stone, trauma, or obstruction, pregnancy test, an older female and ectopic pregnancy. Radiology, you may do flat and upright abdominal film, bowel obstruction, multiple air fluid level, appendiceal fecalith, free intraperitoneal air, renal stone, CT scan, ultrasound, rule out abscess, appendicitis, Crohn's disease, and so on. You may do ultrasound to exclude gallbladder stone, pancreatitis, interception, pancreas, and so on. And endoscopy, upper GIT in cases of peptic ulcer disease or esophagitis. So this table shows you the disease and the presentation of abdominal pain, whether recurrent or acute, or recurrent and the site of pain, referral, quality, and comment. So you can read this table as you see because it is repeated. This one table compare between Crohn's disease and ulcerative colitis metabolic disease. Fortunately, in our communities, is not common, although it is present, probably underdiagnosed, but definitely it is not common like in the West. So you have Crohn's disease presented with malaise, fever, and weight loss, both of them. Rectal bleeding is usual with ulcerative colitis. Abdominal pain is common in abdominal mass is common in Crohn's disease and rare in ulcerative colitis. Abdominal pain is common in Crohn's and common in ulcerative. Perianal disease common in Crohn's and rare in ulcerative colitis. Ileal involvement common in Crohn's disease and none or backwash ileitis. Structure in Crohn's and unusual in ulcerative colitis, and so on. Skin lesion you see common here in Crohn's disease and not present here. Transmural involvement common in the Crohn's disease and not present because it's mucosal disease. Crypt abscesses is usual or common in ulcerative colitis and variable in Crohn's disease. The other thing, mouth ulceration is common in Crohn's disease and less in ulcerative colitis, as well as erythemaneurism, which is common here and less common in ulcerative colitis. Here you see Crohn's disease, cobblestone appearance in the bowel wall mucosa, and this is a skip lesion. They call skip lesion here, disease here free, here disease, here free, and so on. So this is the Crohn's disease. Ulcerative colitis, the mucosal ulceration with the crypt formation, abscess formation. The whole colon may be involved, transverse descending and ascending colon. So diagnostic studies, inflammatory bowel disease, you may check for acute phase reactant, ESR, CL2 protein, usually elevated, not all, CBC differential, anemia, the elevated platelet count, atypical antineutrophilic cytosolic antibody, antigen. You check this. Upper GI series, essential to rule out ileal and jejunal Crohn's disease. CT scan used to detect abscess and small bowel involvement. Tagged white PC scan sometimes helpful in determining the extent of the disease. Endoscopy, you do upper endoscope, evaluate for Crohn's disease involving the esophagus, stomach, duodenum, because all GIT is affected by Crohn's disease, and obtain tissue for biopsy study. Colonoscopy, presence or absence of colitis, terminal ileal Crohn's disease, obtain tissue for histology. Capsular endoscopy, emerging rule for diagnosis, emerging rule in the diagnosis of small bowel Crohn's disease, and more sensitive than upper GI series study. Now we come to the cases of jaundice and altered liver function test. You may have jaundice here. Jaundice, it may be prehepatic, hepatic, or post-hepatic problem, causing yellowish discoloration of the skin and sea clearance. So in case of prehepatic cause, unconjugated hyperbilirubinemia, because bilirubin not reach the liver. So an increased production like hemolysis and effective erythropoiesis, decreased hepatic uptake in cases of sepsis, decreased bilirubin conjugation in cases of Gilbert and Klinger-Najar syndrome. In cases of post-hepatic, there is extrahepatic cholestasis, some obstruction in the flow of the bile, whether intraductal or extraductal. So compression of ductal biliary duct by tumor or mass or cyst or any lesion, or intraductal obstruction. The same thing will lead to retention of bile, and bilirubin will lead to jaundice. In cases of hepatic cause, conjugated and unconjugated hyperbilirubinemia, all of them are present. So hepatocellular cases of unconjugated, and in case of cholestasis, conjugated. So there may be elevated liver enzyme. See the elevated liver enzyme here. So with hepatocellular cause or cholestatic cause. So in cases of hepatocellular, alanine aminotransferase and aspartate aminotransferase are more higher than rise in the alkaline phosphatase. So in case of viral problem, autoimmune affection, hepatitis B, C, and autoimmune hepatitis, metabolic cause like hemochromatosis, Wilson disease, alpha-1 antitrypsin, other cause like alcohol and medication, and toxin affecting the liver. In case of cholestasis, here alkaline phosphatase is elevated more than in cases elevation of alanine aminotransferase or aspartate aminotransferase. So intrahepatic bile duct may be obstructed, or extrahepatic duct here is dilated. Checked by ultrasound, by stone, by atresia, pancreatic cancer, or cyst, or bile duct carcinoma. Cases of intrahepatic cholestasis like infection, viral, bacterial, and granulomatous disease, infiltrative disease like malignancy and amyloidosis, autoimmune, primary biliary cirrhosis, or primary sclerosing cholangitis, and alcohol and drug intake. Here, hepatic dysfunction approach, a child with hepatic dysfunction or failure, you may see CNS is involved, affected by encephalopathy, disturbance of consciousness, coma, jaundice, epistaxis because of coagulation factor are affected badly, case of hepatic failure, cholestasis lead to fat malabsorption, deficiency of fat-soluble vitamins, pruritus, retention of bile salt, pale stool, and dark urine. There may be ascites, hypotonia, muscle weakness, peripheral neuropathy, deficiency of vitamins B6, B12, rickets secondary to vitamin D and calcium deficiency. Varices here present, portal hypertension, spider nevi, small dilated vessels, muscle wasting from malnutrition, bruising and petechiae platelet dysfunction, coagulation disorder, splenomegaly with portal hypertension, hypersplenism, hepatorenal shutdown or failure, pulmonary erythema, clubbing of the finger, and loss of fat store secondary to malnutrition. All these may be cases of hepatic affection. Now we come to the cases of viral hepatitis as a cause of jaundice, and you may see it now and then, especially in our locality. And the infectious hepatitis is the common here in our locality. I mean, hepatitis A virus affect the liver, RNA virus with incubation period of 2 to 3 weeks, transmission by fecal oral route, and no chronicity, and pulmonary disease is rare. While in cases of hepatitis B and C, which are transmitted by blood and the blood product or sexual transmission between patient, here the incubation period is 3 to 4 months, and here 7 to 9 weeks, or 160 to 1 to 14 days. Hepatitis D 42 to 21 days, and hepatitis E is oral, fecal oral transmission. You see, most important in community and epidemiological is hepatitis B and C because they are associated with cirrhosis and malignancy. So parenteral nutrition, parenteral transmission, and perinatal is rare, but in hepatitis B is yes, and chronicity is also present in these three viruses. Hepatitis D of derm particle need hepatitis B affection to inflict harm to the liver. Fulminant hepatitis is common in D and B, as well as E. So rare in C and rare in A. Here you see diagnostic test for and serology and viral PCR for these viral hepatitis. Case of B, you check for anti-hepatitis B core IgM, and you check for surface antigen and anti-hepatitis B surface antigen, or you check for DNA particle by polymerase chain reaction. In case of hepatitis A infection, you check IgM antibody against hepatitis A virus or blood PCR positive. Cases of C, you check for antibodies against hepatitis C virus or PCR. The same applied to the hepatitis D virus, IgM antibodies or PCR. You check for hepatitis B surface antigen here because important hepatitis B and D to inflict disease. Hepatitis E virus blood PCR positive for the affection. Past infection or recovered, you check for IgG antibody against hepatitis A. Most of the community children below 5 years, 90% or more may have IgG antibodies against hepatitis A in our community. In case of hepatitis B, you check for anti-hepatitis B surface antigen and anticore antibody IgG. This is recovered. Hepatitis C, anti-hepatitis C virus antibody, PCR negative. Here also PCR negative because there is clearance of the virus. Same applied to the D and E. Chronic infection in cases of hepatitis B, which is very essential clinically and epidemiologically, you check for special blood donors, you check for anti-hepatitis B core IgG and presence of hepatitis B surface antigen positive. So there is antibody, but there is no clearance of surface antigen. Or anti-hepatitis B surface antibody and still positive for PCR for the virus. Case of hepatitis C virus present and PCR is positive. So still the patient a long period of time may have harboring the virus in his blood. So he is infectious or she is infectious. Same thing here, an anti-hepatitis D virus antibody IgG and the blood PCR is negative or hepatitis B surface antigen positive. Vaccination there is a vaccine against hepatitis B and A. So patient received vaccine against hepatitis B may have anti-hepatitis B surface antibody and anticore antibody, but they shouldn't have surface antigen positive or PCR positive, so they will pass into chronicity. Here you check for antibody against hepatitis A virus. This figure shows you the clinical or serologic course of acute hepatitis A, relation between enzyme, elevated liver enzyme, and the symptomatology. So here the virus is present in the stool, and the elevated liver enzyme ALT, which is more specific for the liver, and there is jaundice and other symptoms. Over time, the IgM antibody will decrease first 4 months after infection and start to have IgA continue indefinite as a protective mechanism. And here, cases of hepatitis B, the patient may have hepatitis B surface antigen positive, PCR positive, before the symptomatology appear. So you may do screen for this because the incubation period is high, as I told you, 3 to 4 months. There is also presence of IgM anticore antibody and hepatitis B surface antibody here for clearance of the virus, and this is the IgG anticore antibody. So important here, you see the elevated liver enzyme, and they will get into normal baseline. In case of hepatitis C virus, you may have PCR positive before the symptomatic symptoms appear, and there is some elevated liver enzyme. So there is a course of hepatitis, there is elevation of liver enzyme after with appearance of symptomatology. But I told you PCR may be positive before the patient gets symptoms. Here, natural history of hepatitis B and C, usually they lead to either fulminant hepatitis or death or autologous liver transplant, orthotopic liver transplant, or persistent infection lead to carrier and cirrhosis and hepatocellular carcinoma or chronic hepatitis, persistent or active hepatitis. Or from the start they develop immunity. But the amazing thing here, when you get the virus at younger age, the recovery will be low. So neonate 5% recover, 1 to 5 years 70% recover, more than 5 years more than 95% all will recover and develop immunity. So when get the virus older, you get rid of the virus. When getting the neonate, just 5% will recover from the virus. And fulminant hepatitis may lead to, from the start, 1 to 5. Here, indication and dosing of schedule for hepatitis B vaccine and hepatitis B. You see the universal prophylaxis, infant of hepatitis B surface antigen negative mother give birth to a child and she is negative, you may vaccinate the child. Children and adolescents 11 to 19 years, you can be vax, can give, or this type. Post-exposure, you probably may get this during your work, your job. So by needle sting or exposure to contaminated blood or blood product, contaminated, and for patient with hepatitis B antigen positive, so within 72 hours you should take the vaccine and take the immunoglobulin. So the infant here or the mother was positive, they should receive vaccine and immunoglobulin. they should receive vaccine immunoglobulin at 1 and 6 months within 72 hours. Intimate or antiviral blood exposure, you give the vaccine, if not vaccinated already, and give immunoglobulin. Household contact, exposure 1 to 6 months, you should vaccinate them. Immune compromised exposure, they should receive immunoglobulin. Contact with unknown hepatitis B surface antigen status, intimate or identifiable blood exposure, you should receive vaccination 1 and 6 months. In case of hepatitis C, less than 1% positive fulminant hepatitis and death or liver transplant. Or persistent infection 60 to 80% post chronic hepatitis and cirrhosis with hepatocellular carcinoma. Or eradication at 20 to 40% with normal aminotransferase level, and at age of here persistent infection, they are asymptomatic, but at age 20 to 80 years later may pass into cirrhosis. So the clearance of hepatitis C is very less than hepatitis B. Here, a 6-week-old boy, 6-week-old girl, present with jaundice since 2 weeks. She is deeply jaundiced and has a 4 centimeter hepatomegaly below costal margin. She is feeding well, gaining weight, and continuing along the 50th centile hair growth. The stool is pale. Ultrasound scan couldn't show gallbladder. Liver enzyme is elevated, 300 units per liter. Glutamate transferase is elevated, 290. Alkyl phosphatase is 600. And the bilirubin is mainly conjugated, which is 14 milligram. So what do you think this infant have, or this baby have? Yes, this is obstructive jaundice. All right. So neonatal cholestasis, you check for whether it is intrahepatic or extrahepatic. You see, in case of extrahepatic disease, bile duct injury obstruction or biliary atresia. Intrahepatic disease, bile duct injury or hepatocyte injury. In case of viral hepatitis, metabolic disease, galactosemia, tyrosinemia, and so on. Or idiopathic neonatal hepatitis, sometimes associated with hepatitis B in the mother, or intrahepatic bile duct bucity. Intrahepatic bile duct or bucity of this bile duct lead to stasis. Conjugated bilirubin is more than unconjugated. So investigation you may do in such cases of neonatal hepatitis, serum bilirubin fractionation, you do direct and indirect. Check the stool for clay color or pale stool, indicate bile flow hindered and not pass into the intestine. Urine and serum bile acid measurement confirm cholestasis because they are elevated. Hepatic synthesis function like albumin, coagulation factors indicate severity. Alpha-1 antitrypsin suggest or exclude PIZ homozygous for antitrypsin deficiency. Thyroxine and thyroid-stimulating hormone suggest or exclude endocrinopathy. Serum chloride test mutation in case of cystic fibrosis. Urine and urine amino acid suggest exclude metabolic liver disease. Ultrasound check for choledochal cyst. Triangular core sign suggests biliary atresia. Hepatobiliary scintigraphy, radioisotope study check bile duct patency or obstruction. Liver biopsy distinguish between biliary atresia and suggest alternative diagnosis like hepatitis. So this evaluation, same thing you do for infection, congenital infection, torch or hepatitis, genetic cause of 1-trypsin, cystic fibrosis, galactosemia, metabolic, plasma amino acid, and urinary organic acid. Ultrasound check for gallbladder and bile duct, dilated cholangiogram and surgery. Normal gallbladder or not visualized, you do radionuclide scan and excretion, patent biliary tree liver biopsy, or no excretion, obstructed bile duct lead to biliary atresia and liver biopsy with laparotomy. So this is a high scan liver showing good hepatic uptake of isotope and no excretion into the bowel. This scan suggests extrahepatic biliary atresia or obstruction with severe intrahepatic cholestasis. So, you see this boy with successful bile drainage by hepatoportoenterostomy, or they call it KSI operation or procedure for biliary atresia. You see this a scar of the operation, although still there is some sort of jaundice here. You check them. These are the references from which my lecture was taken. And thank you for your listening. And if you have any comment, any question, any addendum, you can write it down in the Google Classroom or on YouTube channel. Thank you very much. See you.